Let's go to Module 11, Dysuria and Incontinence, Diarrhea and Constipation. So a couple of these have to do with the urinary system and problems with it, and the other ones have to do with the intestinal system or the colon, the bowels. Okay, and we'll see what we got here. Okay. For example, the first thing we have is interstitial cystitis. Okay, this is going to be something that looks like a urinary tract infection, but turns out it is not, but it kind of acts like one, so that's something that we'll see with, the urine part of it. The diabetes insipidus and SIADH, we've seen these before. Again, we're talking about things that will affect the urine flow, so it's worth a review in this section. Benign prostatic hypertrophy, or hyperplasia, sorry, benign prostatic hyperplasia, a very extremely common condition that most men are going to get sometime in their life if they live long enough, they say. That'll also affect urine flow. The neurogenic versus overactive bladder, we'll see a slide on that where you're kind of comparing different reasons why you would have urine flow when you do not want it. Okay, along with that, actually on the same kind of thing here, 4 and 5 kind of go together. Stress incontinence, that's, you've heard of that before, or maybe you know somebody who's like, they laugh and they like wet their pants. Okay, still talking about that. After that, we move on to the diarrhea and constipation part where one is too fast of having bowel movements and one is too slow. Okay, diverticulitis and diverticulosis in the same diverticulosis. Okay, diverticulosis, you would have that before it goes into litis, and we'll see these outpouchings of the colons and talk about those. Ulcerative colitis we kind of look at the same time with Crohn's, because these irritable bowels, or not irritable bowels, these I'm blanking it right now, but these bowel problems are very serious. Okay, these are things where you have ulcers in the colon, for example, and then Crohn's, you could have these other kind of ulcers, not only in the colon but in the anywhere in the digestive system, and we'll look at those. Okay, ileus is basically a blockage. Okay, so we'll look at the blockage and see what some of the common reasons are for that. Irritable bowel syndrome is another one that is fairly common, and we'll look at the irritable bowel syndrome a little bit and see what it has to say to us as far as that goes. And pancreatitis, we've seen that before in the earlier module, but we'll look at it again as a review because it fits into this category. Okay, just a little bit of anatomy review, what we're talking about here, because we will be mentioning, for example, the ureter. Naturally, we won't be mentioning the ureter probably very often, but the urinary bladder definitely, when we're talking about that, when we talk about the urethra, we have to know where that is, and of course the kidneys. We'll get back into that. All right, as far as the rest of this, it's nice little anatomy stuff, but it's there for your reference if you need it. I'm not really going to be talking about it on this video. Interstitial cystitis, let's start with that one. And what is it? Well, what are the main things on interstitial cystitis? If you had to remember something, it's these signs and symptoms of a urinary tract infection, but you don't have a bacteria found. So classically, this is going to present as somebody who has bleeding and pain on urination. It's going to cause increased urinary frequency, as in have to go to the bathroom a lot, but it's going to be a lot more than a urinary tract infection would typically do. Okay, so that's one of the things, that the main things. Okay, now once you start looking at it and you rule out a urinary tract infection because there's no bacteria, then you have to start looking a little more in depth. Okay, so it is chronic, as in it's not like a UTI where it just comes and then you take care of it with little antibiotics and it goes. It's chronic, so, and it does hurt. We think it is autoimmune, okay, and what's happening here is this anti-proliferative factor, this APF, as we'll call it. It blocks your normal growth of your cells in the bladder. So you will see that if this is the normal protective lining of the bladder in this area right here, how thick that is. Well, if you look at the same thing, you can see that the bladder protective lining and the one with the interstitial cystitis is not nearly as thick as this lining was when you had a normal bladder. Okay, well, if your bladder lining is a lot thinner, then you can see where that is going to cause some bleeding and some pain, because now you know you have a thinner wall basically. So with a thinner wall, of course, it's going to cause bleeding and pain. In addition to that, it's going to cause these Hunter's ulcers, they call them, to kind of pop right out of there because they can, well, because you have a thinner wall. Okay, along with that, and the Hunter's ulcers, these hemorrhagic ulcers or bleeding ulcers, as hemorrhagic ulcers, you're going to have inflammation. It could lead to fibrosis, which is scarring of it. If you think about the bladder and you look at this bladder, as the bladder fills up with urine, it has to be able to stretch. Okay, that's one of the key factors of a bladder, is it has to be able to stretch. Well, if that wall, that protective bladder lining wall, is thin, like in interstitial cystitis, then you're not going to be able to stretch as much. Or when you do stretch and you start to stretch and pull that out, with that thin wall, it's going to be even thinner. Okay, think about like a balloon. And if you have a little balloon, this is my really bad picture of a balloon, right, before you blow it up. And if you do that and you start blowing it up, well, originally, you know how balloons are really hard to blow up because they have really thick walls, right? Well, as you get the balloon and you blow it up a lot bigger, then the walls, of course, thin out. Well, it's the same with the bladder. As you blow that bladder up, or not blow it up, but as you stretch that bladder, the walls are naturally going to get thinner because it's getting bigger. And if it already started thin, you can see where you're going to have a lot of urinary frequency, right? Because now the stimulus to go ahead and urinate from the stretched walls of the bladder come a lot faster. Okay, I hope that makes sense. Okay, and obviously it will increase sensation, as in pain. Okay, you will see this, by the way, in females more than males. I don't know if I'd necessarily concentrate on things like that, but you have it. Okay, again, thing without infection, dysuria, painful urination without infection. Urgency just means you have to go a lot, and well, frequency means you have to go a lot, and urgency means you have to go right now. Okay, as far as we know, there isn't a cure for this. Okay, there are some medicines like the pentosan polysulfate sodium, or Almiron, that works in about 30% of the patients. That it'll improve your symptoms, but again, it's not really a cure. Okay, what do you do in the meantime? Well, things that irritate the bladder, like caffeine or alcohol. If you think about it, these are irritants, but they're also very, very big diuretics, right? D-I-E-U-R-E-T-I-C-S. There's probably no I here, right? No, there is an I. Anyway, D-I-U. I don't think there's an E. Anyway, diuretics. And these things make you go to the bathroom anyway, so obviously you'd want to stay away from things that make you do that anyway. Okay? Quick little review on osmolarity. Osmolarity is stuff. Okay? How much stuff do you have in a solution? Okay? This has no stuff in this one. This one has a little bit of stuff. And this one has a lot of stuff. Okay, so as you add more stuff to your solution, then you go from hypotonic, as in low amount of stuff, to hypertonic. Okay, as a more stuff, and it's relative. That's why it shows, from this line over to this line, from this one to that one is 1. But if you're speaking between these two, started with 1 cube in here and went to 2 cubes, and obviously you started hypo and hyper, so it's all relative as far as how much stuff goes in there. Okay, Now, SIADH, we've seen this before. The first thing I hope you are thinking by this time is water intoxication, as in water intoxication. Okay, as in way too much water. Okay, well, why do you have way too much water? Because ADH is anti-diuretic hormone, and a diuretic will make you urinate. Therefore, if it's an anti-diuretic, it will keep you from urinate. Therefore, it is drawing water back in. As it draws water back in to the blood out of the kidney, then it's a really bad kidney, but there you have it. That's my nephron. Draws water back into the blood, then you're going to have a lot of water stuck in the blood. Okay, remember that? What causes that again? Well, in most cases, we don't know. Idiopathic. In some cases, we do know that a brain injury will cause it. Some infections will cause it. Trauma can cause an increase in ADH secretion. Stroke and hemorrhage would naturally cause increased ADH, and then it just goes too far sometimes. Okay? This is the weird one, right? ADH secreting tumor or a bronchogenic cancer is the most common, and it's bizarre. Okay, that's why this is so relevant, I guess, is because it's unusual. So you get this bronchogenic small cell lung cancer, and that actually releases ADH from the lungs. Well, what in the world is that doing? It shouldn't be coming from the lungs. It should be coming from, other places, but it's not. Instead, it is coming from the lungs, and that's obviously a problem. Okay, bizarre that a lung cancer could cause that. Okay, your signs and symptoms. All right, your electrolyte imbalance. Well, back to this whole stuff thing. If you have this many things in your blood, doesn't really matter what they are. We can call them salt, we can call them sugar, we can call them proteins, whatever. And all of a sudden you dump a whole bunch more water into your blood, it's going to dilute it, right? So now you have a lot of water in your blood, and it's going to dilute those things, the stuff, and therefore it's going to drop your osmolarity, right? It's going to drop your osmolarity because even though you may still have the same amount of stuff in there, now you have so much water in there, it just diluted it out. Okay, does that make sense? So it's going to drop all of your electrolytes. It's going to drop your sodium, your potassium, your everything. Okay, and of course, hyponatremia, as in not enough salt or sodium, is something that we definitely have to pay attention to because that has a lot of functions in the body, as we have learned throughout the course. Serum osmolarity versus urine osmolarity. Okay, you would expect the did I say go up? No, I did. I hope I said go down. I can't remember now, but either way, you have more water, and it's going to drop your serum osmolarity. Okay, as in now even though you may have the same amount of stuff, you have more water, so there. Okay, well, increased urine osmolarity. Does that make sense? If I am sucking in a whole bunch of water back into my blood from the kidneys, and I have a whole bunch of water in my blood, I would think that as that blood flowed into the kidneys with all that water, it would want to really dump it. Okay? The problem is it doesn't really matter how much water you dump into these nephrons, because the problem is at the end of the nephron, and when you get to the end of the nephron, the ADH is sucking it right back out anyway. So what's actually being urinated out of the body is going to be low on water. And if it's low on water, then the osmolarity, OSM, is going to be up, right? Because there's more stuff compared to water. Does that make sense? More concentrated urine. Okay, you do want to test it, maybe you get a CT or an MRI, maybe you're looking for that tumor in the lungs, that small cell lung cancer. Okay. Diabetes insipidus is pretty much the opposite, right? In diabetes insipidus, you are lacking ADH. Well, if you are lacking ADH, then the exact opposite is going to happen that had in diabetes insipidus. If this is your nephron and you don't have antidiuretic hormone to pull that water back into the blood at all, well, then the water is going to continue to be urinated out, and now you have pretty much opposite, right? What causes that? A lot of things cause this. Okay, maybe you have a pituitary issue, as in you can't make the antidiuretic hormone, which is from the pituitary gland. So we call that a neurogenic. Okay, neurogenic. It originated. The problem was created in the head, in the nervous system, right? So if you don't have ADH in the first place, maybe it's a pituitary adenoma, then that would be what we're talking about there. Okay, maybe it is a kidney problem, nephron. Okay, maybe an inadequate response of renal tubules to antidiuretic hormone. Okay, so maybe there is ADH there, but for whatever reason, it's just these tubules are not responding. Okay, if they don't respond, it doesn't matter how much ADH wants to go in there. If it can't go in there, it can't go in there. And there's psychogenic, excessive fluid intake. Okay, for whatever reason, people are drinking too much water, and if you drink too much water, then you're going to have, your own self-imposed SIADH, really, except that, it's not an ADH problem, it's just too much water. So if you got a whole lot of water in the blood, that's my water level, in the blood, you're going to have a whole lot of water in the kidney. You have that, of course, it's going to urinate it straight out, regardless of the ADH. Maybe you have too much water in there. If you have too much water in there, why would you want more antidiuretic hormone, right? Because antidiuretic hormone is supposed to take the water back in. Well, if you already have too much water, why would it do that if it's working correctly? Signs and symptoms. You're dehydrating yourself, so of course you're going to have excessive urination and be thirsty. Okay, and poly means much, so much urine and much dipsia, as in much thirst or drinking. Okay, excretion of large volume dilate urine and dehydration. Oh, it's all saying the same thing, right? How do you test for this? Well, you're going to see that it's opposite again. Your increased osmolarity of the serum, as in you got a lot of stuff compared to the water because you have less water, and decreased urine osmolarity because now you're urinating more water compared to stuff. Okay? And that's what that is. And of course you test your plasma antidiuretic hormone levels to find out if, in fact, it is a problem with with not having enough ADH in the first place in your blood. Okay? Let's look at this thing. A little question. A patient presents with a plasma osmolarity of 500 milliosmoles per kilogram. The normal range is up to 300. Okay, what is the most likely disorder? So your plasma osmolarity is increased, right? Increased osmolarity. Increased osmolarity means what again? It means that you have increased stuff in your blood. Well, if you have increased stuff in your blood, that means you probably have decreased water in your blood. Yes? If you have decreased water in your blood, which one is that? SIADH? No, because that's water intoxication. That's too much. Diabetes insipidus? Sure, that would make sense. You have less water in your stuff, in your blood, because you're urinating it all out. And then hemorrhage. Well, if you have a hemorrhage, as in bleeding, then the osmolarity is going to be about the same as it always was, because you are not only bleeding water, you are bleeding the stuff that's in the water. Okay? So, diabetes insipidus. This would probably be a good place to stop this video and move on to the next one because of the time limit. I don't want the video to get too large.